Добро утро на всички, които в момента влизат. На присъстващите бързо се увеличава, вече имаме 105 човека. Нека да изчакаме 2 минути, преди да се проведем всички. Може да отидете да си направите кафе. Докато чакаме хората да се съберат, мога да ви кажа интересна новина от тази сутрин. Обединените нации правят всяка година доклад на световното щастие и традиционно се намираме някъде на последните места. 120-130 места. И това, разбира се, на своето обяснение, но тази година най-много България на 85 място. Това да излезе вчера. 85 място от 120 място. Едно много добро предвиждане. Добро утро на Родина, на Йоана, на Лора, Елица. Добре, разбираме, че преводачите не ме чуват. Вие чувате ли ме? Ако може да напишете в чата дали ме чувате добре, дали трябва да се приближа към микрофона, може би.
Аз те чувам сега добре.
Може би малко по-близо до микрофона. Добре, вижте, вече е 9 часа и 5 минути. И предлагам да започваме. Аз съм Илина Атанасова и съм основател на Фондация Кожа, платформа за психично здраве. Ние се занимаваме с предимно доброволческа дейност в сферата на психичното здраве. Може би сте запознати с някои от нашите проекти. Миналата година направихме първата мека стая в България. Имаме няколко национални проучвания за това как мислят хората за психичното здраве. Имаме малка книжка, която обяснява на малки големи как да говорят за сложната тема за загуба. Както избухна военния конфликт в Украйна, оказваме безплатна психологическа подкрепа на хората засегнати от войната. Като първоначално започнахме с заявки през Фейсбук, в момента имаме централизирана страница, която на заявките. По-късно мога да ви сложа линка в чат. Днес правим това обучение, за да помогнем на всички, които са ангажирани с подкрепата на бежанците, по някакъв начин да имат подкрепа в разбирането за това, което се случва. Имаме удоволствието да имаме доктор Уолтър Бъсътил с нас днес. След като вас ви обясня няколко технически неща, Калина ще ви каже малко повече за това, с което сме се занимавали до момента, как ще протече семинара днес. Успяхме да направим така, че да имаме симултантен превод днес. Ако отидете долу на малка кръгла иконка, на която пише Interpretation, на нея може да изберете дали превода да е изключен, дали да се присъедините към английския канал или да ползвате българския превод, където през цялото време ще чувате само български превод, няма да чувате английския канал. Ако може в чата да ми дадете само бърза индикация дали това е ясно или да обясня по-подробно. В дъното на прозореца на Zoom малка кръгла иконка, на която пише Interpretation. Окей, английски и български. И също така трябва да ви кажа, че семинара, както сме обещали, се записва. След като приключи семинара, малко по-късно днес или утре ще получите запис. Ако някой не е окей с това, може да ми каже или да се изключи камерата или да се изключи звука. И последната техническа част, която трябва да покрием, са въпросите. Ако имате въпроси, има 3 начина да ги зададете. Единият е през Q&A иконката долу в бара с иконките. Там може да напишете въпрос. Имате възможност да харесвате въпроси на хора, които са задали въпрос вече и се повтаря с вашия въпрос, да не се повтарят много въпроси, имате възможност да напишете въпрос в чата. В чата може да си пишете индивидуално помежду си или да адресирате директно панелистите. И третия начин да зададете въпроса, като вдигнете ръка и аз ви дам възможността да говорите, тъй като в момента микрофоните ви сте изключени. Има ли още нещо, което бих могла да сега? Не се сещам. Ако имате въпроси, пишете ми директно или пишете в чата и давам думата на Калина.
Здравейте от мен. Аз съм Калина Йорданова и също с Ирина сме част от този проект Кожа. Имахме няколко идеи за семинари. Единият е този, на който сте днес. Утре ще, заедно с Юнг общество, ще имаме един с доктор Вами Волкан. В настоящия семинар ще си говорим с Уолтър Бъсътил за бежанците, травмата и работата с нея. Неговия опит с свързани с травмата въпроси от 1989 година. Също така има клиничен опит с ветерани, с възрастни жертви на сексуално насилие, бежанци. Също така изследователска работа в Кингс Коледж, Лондон. Как ще изглежда нашия семинар днес, чисто като времева рамка? Имаме около 2 часа. В първият час и 10 минути ще чуем презентацията на Уолтър, след което ще имаме около 5 минути почивка и време за въпроси от публиката. Това е от мен. Уолтър, заповядайте.
Hi, good morning, everybody. I hope you can hear me. Yes? I'm going to share my screen. The host needs to enable me, please, to share my screen.
Can you see the sharing button now, Walter?
Yes. Can you see my screen?
Now we can, yes.
Yes. Oh, that's mine. Yeah. Can you see my slides? Yes. Yes. Okay. So I'm a consultant psychiatrist. I started working in traumatic stress in 1989 when I was in the Royal Air Force. We set up a clinical service for combatants coming back from the First Gulf War. We also treated the British Beirut hostages who were incarcerated by the Hezbollah for 4 years, for example, chained to a radiator. And then when I left the Air Force, I set up services for adult survivors of abuse. I treated refugees as well, especially from the Bosnian wars. And then about 15 years ago, I became the medical director of a veterans charity, which was the biggest service provider in the United Kingdom for veterans' mental health. So today, I'm very pleased to be here. Thank you very much for inviting me. We'll talk today about trauma theory first. So I think it's important to understand the theory behind what we might see in the Ukrainian families. So not only perhaps the refugees, but also those who are living in your country have already lived there for years and know that their families are being subjected to the terrible war, but also then when the refugees come, as it were, we need to have an understanding of trauma theory to then kind of plan how we're going to manage different situations and different presentations. So the second part of the talk will also be about interventions. This will kind of deal with psychological first aid, particularly. We'll talk a little bit about later interventions, which really would comprise treatment, but we're not going to talk a lot about the treatment of chronic traumatic stress disorders today. So if we go to the theory and what post-traumatic stress disorder is and the nature of traumatic stressor. So a traumatic stressor is one that is a situation where the individual is subjected to threatened death or exposed to situations of actual or threatened very serious injury or threatened sexual violence, either directly or by witnessing the trauma or by learning that a friend or a close relative has been exposed to the trauma, and also by being a secondary victim, like a rescuer, for example, the fire services or the ambulance services who arrive on the scene of a terrible accident. And the way to think about post-traumatic stress, so what is post-traumatic stress disorder, is to just bear in mind that many of the theories talk about PTSD as being a disorder of memory. So the stressor is so overwhelming at the time, and if we look at the slide, the top word is stressor there. The stressor is so overwhelming that the mind cannot file what is happening in memory. So at the time, all the mind does is it protects us just to survive. And when it does that, we function very automatically. We either run away or we freeze, but we do not process what is actually happening. Then the rule is later on, the mind has to file away everything. That is the rule. And we have to file away the facts of what happened, the sensations, and the emotional response. And that usually goes in one bundle, in one part of the brain, in the amygdala, where information processing starts. And then once that is completed, the memory is stored in the hard drive of our brain, which is like a computer, in the hippocampus. So PTSD is a disorder of memory. And what happens then is, once the trauma has gone, we start to re-experience the trauma. We get nightmares and flashbacks. We also get memories in our body, as it were, where we become very anxious and suffer physical symptoms of anxiety with palpitations and sweating, for example, if somebody exposes us to a reminder of the trauma, and we can feel emotionally very upset. And then our body gets stuck, as it were, our mind gets stuck in hyperarousal and emotional numbing. And that's the second symptom cluster of post-traumatic stress disorder. And that's really unpleasant. And then we learn automatically that the best way to cope with all this is to avoid anything to do with the trauma. And the more we avoid, the less likely it is that we're ever going to process the information. And of course, avoidance in some cultures means that we will use alcohol, for example, or use cannabis. And avoidance can also mean that we isolate ourselves and we become depressed. And of course, emotional numbing is not pleasant at all. And people will use drugs that make them feel their feelings. For example, they smoke a lot of cigarettes because there's nicotine in the cigarettes, or drink a lot of coffee because there's caffeine in the coffee. And they'll use amphetamines, cocaine, and ecstasy. So post-traumatic stress disorder is a package. So you get the three core cluster symptoms of re-experiencing hyperarousal and emotional numbing and avoidance. And added to all of that, we get a very negative aspect or outlook towards ourselves and the world and other people. So we get a negative cognitive change as well. And of course, we then have a comorbidity, which is to do with using drugs and alcohol, and also to do with depression. So post-traumatic stress disorder is a package, and that's really what we will be seeing in some of the refugees who come back from Ukraine. So that model, the first model I described, is the information processing model. It's quite an old model by Marty Horowitz in 1976. And there are other models of psychological theory now that have, if you like, built on that. So one is the psychosocial model. So that's about social support before, during, and after exposure. So the more support you have before, during, and after exposure to the trauma, the less likely it is that you'll develop PTSD. And if you do develop it, the more likely it is that it won't be severe if you have support. a behavioral model talks about triggers. So that's really important that we look at triggers when we're doing our therapy. So for example, if there's an assault and I'm being beaten, but I'm lying down on a lawn of grass that's been freshly cut, the smell of the grass, the texture of the grass, the color of the grass will act as a trigger later on and can bring on flashbacks of the trauma. When we talk about cognitive models, we talk about distortions or hotspots. These are difficult parts of what happened that we really don't want to confront. So for example, that I let my friend down, or that I should have done something in a different way, or that I thought actually I was the only one trying to save that person's life and I didn't know there were lots of other people trying to get into the burning house, other firemen trying to get into the burning house from the back door, as it were. So these are cognitive distortions that can be big barriers to me getting better. There's a model called the cognitive appraisal model, and that's all about the meaning of what happened, the meaning of the trauma, and that's really quite important. We'll talk about moral injury in a few minutes as well. So is this an act of God? Is this just bad luck? You know, for example, I bought a house, it was on a volcano that was extinct for 200 years. And after 200 years, the volcano erupted and I just managed to get to escape with my life. That is a very different kind of trauma as compared to I was walking in the street and somebody maliciously tried to stab me. So that is a very personal assault, just like we're seeing with the bombings, for example, in Ukraine. That's a very personal thing, wanting civilians to be killed. There are a lot of memory theories. We've talked about memory theories, so that's the dual representational theory. So what is accessible to me, what I can actually talk about, and what I cannot talk about. Part of my brain is suppressed, what happened, and people can't really even express the horror of what they've been through. And there are a lot of theories in relation to that, with the biology of what is happening in the brain. As we've explained, the amygdala is the important center there that normally processes information. But next door to the amygdala, for example, there is the language center, and next door to that, there is the writing center. So when people say, I can't even express what happened, I couldn't put things into words, then the reason for that is very biological, and that's quite important. The other theory that's quite important is an attachment model. So it's important to bear in mind attachment when we're doing psychotherapy, because we want the individual to become attached to the therapist, to be able to tell the therapist the worst thing that has happened in their life, and people need to feel safe. So we need to bear in mind that people who have poor attachments or don't trust, if you like, other people will find it very difficult to engage in therapy. There are some emerging models in relation to genetics. So we've known for quite a long time that children of those who've been traumatized have a vulnerability to develop post-traumatic stress disorder after they've been exposed to their traumatic stressor. They're more vulnerable than other people. And what's been shown is that on the chromosomes of our eggs and sperm, so of the gametes, there can be abnormalities if we've been traumatized and suffering from post-traumatic stress disorder. And this is in the telomeres. So this is the end part of the chromosomes of our gametes, of our eggs or sperm. And we pass these on to our children. And this is the reason why people are more vulnerable to developing PTSD if their parents have been exposed and their parents suffer from post-traumatic stress disorder. If we look at a timeline in somebody who's been exposed to serious traumatic stress, we talk about an acute stress disorder or a post-traumatic stress reaction initially. So for the first month or so, the symptoms are very, very fluid. They're not fully formed. And the vast majority of people who are exposed to trauma will not go on to develop post-traumatic stress disorder. What will happen is that their symptoms will spontaneously resolve. And that's really important, to bear that in mind. So for the first month or so, there's no real need to start delivering therapy unless people are really, really ill. What we need to be doing is to support people in the first few weeks. So the vast majority will not develop a long-term mental health problem, but some will. So after 1 month, we start talking about acute post-traumatic stress disorder. And then after 4 months, we start talking about a fixed disorder or chronic post-traumatic stress disorder. And in military psychiatry, this translates into combat stress reactions. So it's very important, perhaps now, to bear in mind what we can learn from military psychiatry and to learn about how the clinical presentation can occur in soldiers who break down on the battlefield. So there are 3 different kinds of combat stress reaction. The first is a breakdown even before the war starts, even before the first shell is fired. And people can break down and display symptoms of high arousal, restricted interest, severe symptoms of anxiety, emotional dysfunction, social withdrawal, sustained criticism and mistrust of their leadership, of the hierarchy. When combat then breaks out, when the war breaks out, we get a classic breakdown with dissociation, cognitive impairment, confusion and disorientation. And then for some, usually the leaders, those who can't afford to break down during the battle, after the battle is over and even after they're out of the war zone, that's when they break down. So they get mood disorders, depression, guilt and shame, intrusive thoughts, so symptoms of post-traumatic stress disorder, sleep problems and irritability. So it's quite relevant, quite important here. So if we kind of have the end of the war and if you like, the families being reunited now, the mothers and children and older people have been in Bulgaria or whichever country as refugees, and then the combatants come as well, we might actually see a breakdown, a delayed breakdown in the combatants later on. But equally, with the refugees you'll be seeing, you might have a similar pattern of breakdown as well. But we'll talk more about the specifics of refugees in a few minutes. So the combat stress reaction research is equivalent to the acute stress reaction research that people have done in civilians. And most of this will spontaneously resolve. So that's really what's important to take home, as it were. So most people will not need treatment. They will need support. Support is a different thing to treatment. We'll talk about that. But with some, there can be interventions that we can take to help this resolution. So rest and basic support, basic needs, for example, helping with sleep and good food. But for some, they will need to challenge some negative thoughts. So we would use some cognitive-based basic intervention. So that's really kind of at the very early stages in the first few days, the first few 2 or 3 weeks. And then, of course, those who do progress don't always progress to post-traumatic stress disorder. They may progress to other mental disorders, for example, anxiety and depression and alcohol problems, as well as post-traumatic stress disorder. But of course, it's really important to bear in mind that all the research shows that the main factor for developing post-traumatic stress and acute stress disorders is a dose-response effect. And what that means is the more you're exposed to terrible events, the longer you're exposed for, the more grotesque it is, the more personal it is, then the more likely it is you will develop your breakdown, your traumatic stress breakdown and acute stress disorder, and then post-traumatic stress disorder. So just to emphasize with this slide, acute breakdown can lead to longer-term mental illness, but not just post-traumatic stress. It can lead to an adjustment disorder or depression or anxiety or alcohol or substance misuse or post-traumatic stress disorder, or even a combination of all of these things. So it's quite important just to bear that in mind. But in the acute phase, the main intervention is going to be support. if we look at military psychiatry again and look at the risk factors in the war theatre, again, the research shows that it is the primary factor that causes a combat stress reaction is a dose-response effect. So that's really, really important. So the intensity of the battle, how unpredictable the stressor is, and then the loss of social support or social cohesiveness of the combat unit. Unpredictability of the stressor. If we know the enemy is opposite us and firing bullets, that's very easy to cope with, perhaps. But if there are shells coming at any time from anywhere, then that's very unpredictable. That's very stressful. And we can actually apply this now to the civilian population that are being subjected to these kinds of traumatic stressors in Ukraine. There are secondary factors. So if in the military you're trained as a cook or a mechanic and suddenly you're put in the front line, then that will have an impact on you. If there's a lack of ability to deny what is happening, to pretend you're not being exposed to real serious danger, then that is a problem as well. If you see a lot of atrocities, for example, if there are conflicts before going into combat, if your family or your wife leaves you before you're being deployed to fight, then that is a big problem as well. And then, of course, we have basic things like, you know, enough sleep, enough food, enough drink, physical exhaustion, infection or illness, which is very common in a war, in a battlefield as well, poor weather conditions. And then, of course, we have other factors like support deprivation. So this is about leadership failure or the death of a leader who's much loved, or else if you get isolated from the basic unit, or you're a new soldier in the unit and nobody knows you, or else if your loved ones at home don't support you going off to the war and think the war is wrong. So these are really quite important factors when we look at military psychiatry. And there's a lot of application now for what's happening in the war in the Ukraine. How common is post-traumatic stress? Well, it's very common, really. In the United Kingdom, it's about 4.4% of the population, and that's kind of everybody due to all kinds of things. So car accidents, personal assaults, abuse, and veterans and war, for example, as well. In America, it's higher. That's probably because of higher rates of interpersonal violence. And there are a lot of varying studies, but it's said to be commoner in females, in the younger people, and the elderly. And the reason for females is that when females are in their reproductive years, for some reason, and that is a hormonal reason, they're more likely to develop post-traumatic stress disorder if they're exposed to trauma. But when they stop being in their productive years, so in the menopause, the rates of PTSD revert back to what they are in males. And being younger or the elderly, that's about information processing and cognitive processing and developmental issues. When we look at war refugees, PTSD is very high. About 25% of refugees can be expected to be suffering from post-traumatic stress disorder. And there I've given a list of other occupational groups, for example, security contractors, 33%, humanitarian workers, 30%, between 7 and 30% of combat troops, 20% of ambulance workers, 25% of war reporters, and 20% of firemen after a disaster. So there is a selectivity, as it were, and the nature of the trauma, the dose of the trauma is very, very important. This is a very large study conducted by Professor Bruin at University College London, and they examined a lot of risk factors for post-traumatic stress disorder, including being female, a younger age, a lower educational status, a lower intelligence, the race, what race you were in, or where you were in a minority, past psychiatric history, history of previous trauma or childhood abuse or adverse childhoods, and the family history of psychiatric illness. But the main effects were found from trauma severity, so again, the dose response, the lack of social support before, during, and after exposure, and subsequent life stress. So life stresses that happen after exposure. And we know that life events are stressful. And if they're negative life events, then of course they're more stressful perhaps, but even positive life events like having a child can be quite stressful. So that's really important when we bear in mind the impact on refugees, for example. Not only have they been exposed to terrible trauma, maybe some will feel rejected, having left their country, they don't feel welcome in a different country, so there's lack of social support. And then perhaps they have to live in accommodation they're not happy with, or they have no money. And of course, they haven't heard from their loved ones back home. So what about the clinical presentation? Well, on average, if somebody suffered from post-traumatic stress disorder, there's a very long delay between being exposed to the trauma and developing PTSD, and then the clinical presentation for help. So people don't come forward for help with PTSD. In civilian populations, the average is about 10 years. In veteran populations in the UK, it's about 14 years. So a lot of the reason for this is that avoidance is one of the biggest symptom clusters of post-traumatic stress. People would rather not confront what happened. They're afraid to do it. And of course, the last thing they want to do is to talk about their terrible experience to somebody who they don't know. And if they don't feel safe, they will not talk. This is why delayed presentation is extremely common. The other problem, of course, is there's a lack of clinical services that are expert at treating this condition. And the other problem, of course, is that generally mental health practitioners, especially psychiatrists, I think, psychologists are a lot better, but psychiatrists and other mental health workers, maybe not psychologists, are not very well trained to ask about trauma and to take a trauma history. So the services are not really there, and that's a lot of the problem. We have this phenomenon of delayed onset post-traumatic stress disorder. Now, this is quite interesting because when you take a history, there'll be a history of trauma, but then no history of symptoms. And then what tends to happen, there'll be a life event like retirement, for example, or else changing a job or losing a marriage. And then suddenly all these symptoms of post-traumatic stress will be evident in relation to that trauma history. So we call this delayed onset post-traumatic stress disorder. And the reason for this, from a psychological point of view, is that many people who've been traumatized cope just to function and solve problems. They problem solve and they don't think emotionally. And the reason for delayed onset PTSD is when people have to start thinking emotionally or have the time to think emotionally, like, for example, when they retire, that's when their nightmares and flashbacks start. That's when they reflect on the past. So it's really important to bear in mind. With veterans in the UK, delayed PTSD is common when they leave the military and they don't have their social support anymore. They have time on their hands because they haven't found a job. Or else when people retire at the age of 65, they've had a very difficult war in the Second World War, classically. And then they've had to rebuild the country. They've had to find jobs, have families. But then when they retire for the first time in their life, they actually then have a delayed onset post-traumatic stress. So with refugees, it's very important to bear that in mind because refugees will have this period where they go to a country and they have to rebuild their lives and they don't have time to be ill. They don't have time to think emotionally. What they need to do is solve problems, look after their children, bring their children up, get a job, put food on the table. That's their priority. So delayed onset PTSD is something that will be seen in refugee populations and is not uncommon. We talk a little bit about secondary traumatization. We've talked about this before because now it's included in our diagnostic statistical manual, 5th edition of the American Psychiatric Association. So now this is properly recognized. So people witnessing what's going on. So on television, for example, if I knew my village was being bombed, I saw my house on television, I had a text message from my mother that they were being bombed, that can traumatize me. Even though I'm safe in another country, I'm a refugee, that can really traumatize me and cause mental health problems, including post-traumatic stress disorder. So secondary traumatization is a well-known phenomenon, and we need to be aware of it. This is a slide about comorbidity. I'm not going to go through the whole slide, but I'll briefly talk about it. So it's important perhaps to get translation of the slide later on. So there are biological, psychological, and social comorbidities with post-traumatic stress. From a biological point of view, people who suffer from post-traumatic stress are more likely to have a stroke or a heart attack, high blood pressure, become obese, get diabetes, and die 10 years prematurely. If they have pain, it's more likely to be perceived as more severe, even if the pain is not caused by the traumatic stress. So there are a lot of biological, physical illnesses linked to PTSD. The other thing is psychological. We've talked about depression, anxiety, phobias, panic disorder, alcohol and drug disorders. So psychologically, there's a lot of comorbidity. Socially, there are a lot of issues. So suicide is very high, higher than what you'd expect in a normal population. Violence, including domestic violence, criminality, unemployment and social slide, homelessness, divorce, and then reckless behavior, like being involved in road traffic accidents because people speed. So it's very important just to bear in mind that this is a very big package of potential mental illness. I'm now going to turn to moral injury. So moral injury is a new concept that's emerging, and that's about everybody having their own moral code, a religious code, an ethical code that we're brought up in. And what's happened in Iraq and Afghanistan in the wars is that the padres, so these are the priests who were with the American military, noticed that many soldiers were going to them and telling them that they were very upset that they were doing things that they didn't feel were right. For example, they had to shoot children who were waving weapons at them or had weapons, and they thought that was ethically and morally wrong. Or else in the Iraq war, for example, the British military were told that Saddam Hussein had weapons of mass destruction, and many of the soldiers I've treated have said to me, that wasn't the case, and I don't believe that was a just war. So moral injury is really important. It's about violations to deeply held beliefs. It usually occurs from cumulative events. So things build up, not only where the weapons we had didn't work properly, the leadership was very poor, but the war was unjustified, and they made us hurt people we didn't want to hurt, and that betrayed my moral code. So it's really important to bear this in mind. Now, moral injury is not a mental illness. It doesn't lead to mental illness, but it can exist with mental illness. We don't quite know how best to treat it, but it's all about forgiveness, forgiving myself, and accepting what has happened. So one needs to bear moral injury in mind when we're looking at interventions as well. We also need to bear in mind traumatic grief. So there are new concepts now in the International Classification of Diseases 11th edition of the World Health Organization and the Diagnostic Statistical Manual 5th edition, where we talk about persistent complex bereavement disorder or prolonged grief disorder. And of course, wars and disasters will cause loss of loved ones. And these complicated grief presentations will impact on people's mental health in their own right, but also they will be potentiated, so they'll be prolonged due to flashbacks and nightmares if you're suffering from post-traumatic stress, or rumination from your depression. So grief reactions are very important as well, and usually they're going to be difficult in terms of being able to treat them. On the other hand, there is good research to show that some people exposed to trauma become more resilient. They become, if you like, more able to sustain personal control over situations. They're more able to confront change, and they're more committed, as it were, to a situation to make things better. And post-traumatic growth has been described, and this is about people growing through trauma, seeing new possibilities in their life, better relations with others, being stronger, and having, if you like, more spiritual dimension to their life and appreciating life. So post-traumatic growth is a phenomenon that can actually occur after being exposed to trauma, can also be present if people have been suffering from mental illness due to the trauma as well. So it can coexist. So what about refugees? Well, they've been exposed to many stressors, including the war experience itself, perhaps torture as well, how they've escaped, their experiences escaping and traveling. They've lost their country, their culture, their status, and their family. They've witnessed death and had near-death experiences. And then after they've migrated out, after they've arrived in their country, in the new country, their future is not secure. They might end up in an internment camp. They might risk deportation if they're not welcome in that country. They have to adjust to the new surroundings, and they have to rebuild. And that's really quite important as well, the rebuilding phase, because that will interfere with whether or not they want to engage in therapy or they can engage in therapy, because they have to, as we said before, problem solve and put food on the table, as it were. So most research in relation to the effects on war zones on civilians are to do with refugees, really. So these are the most common studies. So the studies have shown very high rates of post-traumatic stress disorder and depression and common mental disorders, especially if people have been exposed to trauma. So for example, in Bosnian refugee studies, about 20% suffered from depression and post-traumatic stress. 25% had post-traumatic stress by itself, and a third were depressed. So it's very important to bear in mind that there are very high rates of post-traumatic stress disorder. And the actual nature of the trauma as well, we've talked about it before, whether it's predictable, like shelling is not predictable, the invasion of the country, poor leadership, good morale or bad morale, losses, personal losses of your family and neighborhood, separation from loved ones go out to fight, atrocities, rape as a weapon of war. Well, that is a very difficult thing to treat refugees. That happens as well. I've certainly seen it with African and Bosnian refugees, where one culture, as it were, wants to dominate and destroy the other culture by impregnating their genes, as it were, and wiping out another culture. And of course, we've talked about moral injury. So there's a lot of traumatic situations as well. And then there are vulnerable people, the elderly, children, those hospitalized, those in institutions, the poor and disadvantaged, those who need medications as well, essential medications for diabetes or high blood pressure, and those with disabilities. There are definite syndromes or conditions that are caused by torture. Ultimately, torture is all about an emotional or a psychological, has a psychological effect, no matter how it's perpetrated, whether it's physical or sexual or whatever it is. But acute stress disorders and post-traumatic stress are very common. Survivor guilt, that you survived and your friends didn't, very common. Major depressions, very common. And of course, physical symptoms, brain injury from being beaten, that's very common as well. And heavy metal poisoning, food, vitamin deficiencies, especially in those who've been tortured for a very long time. We're now going to turn to separations. There is a literature on prolonged separations under threat of death, and this is military psychiatry primarily. When people go off to fight, their loved ones remain behind. There's a spectrum of disturbance. The reaction depends on the nature and the duration of the separation, and the coping of the family members left behind determines the outcome of the family reintegration later on. So how the family copes when the loved one's out fighting the war will determine whether that relationship, that marriage survives properly, or how it has to adjust. So it's really important to have a strategy as to how you're going to support these families where the husband, now I think probably the husband mainly, is still fighting in the Ukraine, and the mother and the children are refugees in your country. Because there's a lot of disturbance that people can display. So these are the military, this is military psychiatry and military families. They go on peacetime exercises, they then go to war, or they may be held prisoner of war, or be posted missing in action. Perhaps they've been killed. So all of these conditions can cause mental health disturbances. And the main concept here is anticipatory grief. So this was described in the Second World War by Lindemann. So this is not a new concept. This is about the wife being so concerned the husband will not return that she goes through stages of grief. And what tends to happen is she'll either become very independent and manage everything, or she won't be independent. She won't complete this grieving. She will keep the husband in her thinking. And although she will appear dysfunctional while the husband is away, actually that is better for the relationship when the husband comes back. So the key here is, if you let the anticipatory grief complete, if the grieving process completes, the relationship might be compromised when the husband returns. So that's really quite an important concept. So all conditions of separation under threat of death will cause initial shock, despair, and detachment. There'll be an initial grief reaction with anticipatory grief, but if this completes, then the relationship might be at risk. But if not, they won't cope well during the separation, but that's okay for the marriage in the long term. They'll have symptoms of anxiety, post-traumatic stress, psychosomatic symptoms. They'll drink alcohol, they may use drugs, they may be socially indiscreet, there'll be financial problems. And the symptoms of the mother usually are reflected in the children. So that's important to know as well. So there could be quite a lot of psychological disturbance, which you'll think, well, I better treat this. Unless it's a frank illness, it's probably better to support it and to keep the husband in the wife's thinking. So that's really, really important. So when you support families during separation, the coping pattern of the mother will influence the children's coping pattern and probably will determine it. Whether or not there are psychiatric symptoms in the mother's presentation will predict the development of psychiatric symptoms in the children. Maintaining the husband's memory during the separation is very important. And although the mother and the children may be a bit dysfunctional and emotional and not cope very well, the anticipatory grief will not complete. And that way you'll support her until the family is properly reunited. So it's really, really important that these theories are borne in mind. And ideally, there should be intervention for all the family, support for all members of the family, practical support, encouraging independence, but not all independence, as it were. So, you know, where the husband's return is expected. So if, for example, you had to make a big decision, in theory, she'd need to think about what the husband would want as well, rather than just deciding by herself. So if she's delivered a baby the husband hasn't seen, she needs to decide what name the baby has. She'll need to kind of think as well what the husband would want as well. So psychological support is important rather than helping to complete this grieving process. So that wouldn't be ideal at all. And of course, they can present with physical illness that can be somatiform. They can present with psychiatric symptoms. They can feel suicidal. So you'll need to risk assess that and make sure that that can be, if you like, mitigated and treated if needs be. If they're properly, formally depressed, you'll need to treat that. If they're using alcohol, they become addicted, you'll need to treat that. But help delivered during separation should be linked to the planned help that will be delivered when the family is reunited. So that's really, really important as well. What about other members of the families, mothers and fathers and brothers and sisters, well, there are no studies. We don't know what the effects on these families are, on these family members are. So we just need to bear in mind what we learn from the main nuclear family that I've already described. What about the effects of social media and instant communication with textings and mobile telephones and the internet and webs? We don't know the whole effect of this on the family that's separated under threat of death. It's probably good for morale. It keeps the family in mind. It's important if there are difficult decisions to be made or issues to confront, but it's unknown. You know, if the husband dies or there's bad news or they're injured, it can have good and bad impact. So if you're supporting somebody and suddenly there's a total change, you might find out that actually they've had bad news from the war front, from the husband, that something terrible has happened. It can also cause frustration with the husband fighting and he has bad news, or else he wants to be present for the child's, the birth of his child, and he can't. So we don't know, there's no research really to show what this instant communication can deliver. Let's talk a little bit about intervention. So we've talked a bit about intervention in relation to the spouse or the mother and the children in the safe country now. Now we're going to talk a little bit about interventions, looking at a disaster community. So it's important to identify who's in this disaster community: the civilians in the war zone, the combatants, rescue services, humanitarian and relief workers, the refugees, and the press workers. Those are the primary victims. The secondary victims are the relatives at home. So the wives and the children who have now escaped, they are refugees. They've maybe been not exposed to conflict, and humanitarian staff working from safe countries. That's the whole disaster community. So if we're preparing how to manage their health, their well-being, we would be looking at the WHO, the World Health Organization's recommendations on psychological first aid. And that's really the most important intervention. It's not a treatment, it's about people and being encouraged to use their own resources. So it's close support and help. It's to promote safety, to stay calm, to connect people together, to help themselves and help others, and to hope for the future. And if people want to talk about their experience, that's fine, but we don't do it in a therapy session. We don't force a catharsis. We just support people if there's a catharsis. So the principles of psychological first aid is really what you need to be doing in the first few weeks and months with the refugees coming out of Ukraine. If people then have a mental illness, you'll need to treat that. So you'll need to keep a watch out for it. But actually, the main intervention is going to be on these principles. So it's safety, calmness, connectedness, connect people together, family groups together, people from the same village together, and make sure that there's a group efficiency or efficacy where they support each other in the hope that things are going to get better. And that's really how you're going to deal with thousands of refugees, not just a few hundred, but thousands of refugees. You're going to do psychological first aid. You cannot treat everybody, but you need to keep an eye out and have a service for people who do present with serious risk or mental illness or suicidal thoughts. So that's really quite important. So you essentially check for safety, you look. These are the principles laid down by the WHO. You look and check for safety. You check that people have their basic needs urgently sorted out. So if they need their medication, we get it. If there's a serious distress reaction, that we support them. We listen to them, those who need support, to their needs and concerns, and make them feel calm. And then we try to link them up and access services. So we do need clinical services, but not for everybody, for the minority, where they help people to cope with problems. We give information and we connect people. So those are the main principles, really. And the key components would be to comfort, and console, and educate about normal response. Most people will have a normal response. It is very upsetting to lose your country. It's very upsetting to have dreams about what happened. Most of those dreams will go away. Most of the acute stress disorder will resolve by itself. Care for immediate needs, you know, hot food, somewhere to sleep, a watch, a mobile phone, somewhere to link in and connect with people, protect them from distress or further threat, give information about coping, support on very practical tasks, and connect with social support. And of course, if we're running a field hospital or a refugee camp, these would be the principles. We'd have disaster managers. We would have a mental health team with nurses, psychiatric nurses, psychiatrists, psychologists, and therapists. We'd work with primary care and with commanders. We would listen, validate, and normalize. And we would use those same principles of people being safe, empowered, self-reliance, hope, connectedness, and looking at their needs. But there'd be very minimal intervention and treatment. It wouldn't be a huge amount of treatment. So in the acute phase, with refugee management, what you need is a safe zone for everybody. For yourself, who's working with the refugees, you need to be supported. You probably need breaks as well, people that you can talk to. But equally, for the refugees, then you need a safe zone, safe accommodation, connected to a community with education, education about trauma reactions, and then to treat those who need it. And of course, the social support, as we said before, support before, during, and after trauma exposure is very, very important and mitigates against long-term mental illness. Support is the very best thing you can do, and it's cheap, and it's not a treatment, but it's a very important thing to do. Education is very important as well. If people are there for weeks and months, education about symptoms and how to self-help, you know, with interventions. And then those who have an acute mental health problem, they need to be identified and, if you like, treated as well. So it's a whole kind of mixture of what is required. In Australia, I was present at this in 2015. We developed a longer term intervention that was very low key. It's called SOLAR. So it's skills for adjustment and resilience, for life adjustment and resilience. So it's about empowering the individuals with education, and it's a whole manualized program. So it does not need to be delivered by mental health practitioners. It can be delivered by, if you like, intelligent managers who've had maybe 1 or 2 days training. And it's a short intervention of 5 weekly sessions with people who are undergoing mild to moderate distress after trauma, to learn skills to help them manage and support their emotional recovery. So it's about education in relation to how to be healthy in your living, you know, eating properly, good sleep, routine, how to manage strong emotions, how to come to terms with what happened with the critical incident, how to get back into your life, how to manage worry and rumination, and then how to manage healthy relationships. So I've put a web link there for you to look at Phoenix, Australia. You can ask for the manuals if you want to, but this is a longer term thing. So in the next, I don't know, if you're managing a refugee population for 6 months, then perhaps this would start to be useful after month 3 as a global thing. So there's a lot of material there for you to tap into. And that's, if you like, it's not heavy in terms of needing lots and lots of skill to deliver this. So I think that's quite important. Don't forget with treatment that if you're going to treat, you need to assess. So you do need a clinical team. You do need expertise for those who are really unwell. You'll need to assess post-traumatic stress reactions, perhaps, but also post-traumatic stress disorder, anxiety, adjustment disorders, traumatic grief, the effects of separation and loss, and then, of course, also the effects of physical injury. So that's quite relevant then. So you are going to have a tier of clinicians who are experienced in treating refugees and traumatic stress, and they can have complex presentations. And really the main issues perhaps as well is cultural and the stigma of going for help. We know people are very proud, especially if they've just escaped their country. They don't want to show they're weak. And there's this building phase of refugees that they avoid engaging in treatment, and they'll drop out from treatment because they know they have to earn a living or make a new life in a new country, or to cope managing their children whom they're worried about. So treatment may not be the first thing that they want to access. It will be support and getting their life in order. And it's important as well that if people start treatment and they engage properly, that they complete treatment. So treatment mustn't be over elaborate. And of course, we have problems with language perhaps and interpretation of what's going on. That's difficult. And of course, if you're going to treat post-traumatic stress, you'd use trauma-focused treatment interventions. In the UK, the United Kingdom, we use trauma-focused cognitive behavior therapy or eye movement desensitization and reprocessing, EMDR. I'm not going to go through any of these in great detail, but the basic principles of treating post-traumatic stress are to make sure people are safe and stable. So you might want to treat alcohol intoxication or depression first. You might want to make sure they have somewhere to sleep and they feel safe. And then they'll have to work through and disclose what's happened. They can do that verbally by talking about it, using trauma-focused therapies, or they can write about it using a narrative exposure therapy technique, for example. But of course, they have to feel safe with you as a therapist. So attachment to you as a therapist is very important, that they are able to trust you and they're in this big therapeutic window where they feel safe enough to tell you about the worst thing that's happened to them. And of course, throughout the intervention, we need to know that the intervention will end and that they'll be integrated back into society. They'll reintegrate, they'll get their routine going, and that's really quite important, that there is a reintegration attitude or stance throughout your therapy. There are many pitfalls to therapy. So the nature and duration of the trauma, the role in the trauma, that they kind of skip all the line and get on the train and get out, and that was the last train out. Do they feel really guilty about leaving people there? The meaning of the trauma, how personal was it? They bombed the shelter that all the families were in, and many died, but I survived. Why did I survive? Has the trauma ended? We're still seeing all this on television. The trauma has not ended. Are they safe? Are they isolated? Do they have support? Are they feeling guilty about what they should or shouldn't have done? Are they feeling guilty about surviving what happened? Are they ashamed? Are they blaming themselves for what happened? Do they blame someone else? Are they angry? Do they have a grief reaction that we haven't really discovered yet? Or is it a complicated grief reaction? And is there moral injury? Moral injury is a very important barrier to people getting better. And do we treat comorbidity first? Do we treat depression first? Or do we just treat the post-traumatic stress? What about suicide? What about the risk? Very important. What about alcohol? Do you need a detoxification? Do you need to have somebody withdraw from alcohol in a hospital? Are they motivated to get better? Will they cooperate with treatment? Are they going to comply with treatment and stay in treatment? And then, how good are you? Are you a therapist who knows what they're doing? Your qualities are good enough to treat this patient? And the patient, are they psychologically minded or not really? Will psychology actually help them or not? So when you set up a service for any population that's been traumatized, ideally they should be user-friendly. There needs to be a lot of information. The barriers to care need to be mitigated. So they can be done online, for example, or they can be done at times when people are available. And you need to promote engagement in the treatment and the completion of treatment. There's no point setting up treatment services where people don't engage or complete. It's a waste of money and a waste of time. The service really ideally should be assessing the individual, ideally using clinical assessment, but also psychometric assessment. You need to decide whether medications are going to be useful. So you need psychiatry or at least general doctors to prescribe medications for sleep, for example, but also for depression. And of course, some medications can mitigate against post-traumatic stress symptoms directly. And then you need to decide what kind of therapies you're going to deliver, whether it's outpatient, online, and very rarely it would be inpatient nowadays, and what support and safety measures are in place. So here I've put down a psychometric protocol. I think when you get the slides translated, have a good look. So there are measures for post-traumatic stress, measures for depression, anxiety, and alcohol, and measures for function. Those would be the least that I would recommend. At least you have a baseline when you start assessing the patient. Some of these measures are clinician delivered, they're structured interviews that can take a long time to deliver. Others are self-report. So self-report are probably easier, but they're less accurate. So that's a list of what, for example, we are using in our service. The clinician administered PTSD scale, so the CAPS, this PTSD symptom interview, these are structured interviews. The impact of event scale revised for PTSD, or the PCL, the PTSD checklist. And then for anxiety and depression, the generalized anxiety disorder scale, the general health questionnaire. And then you could measure alcohol using the alcohol use disorders identification test. So there are lots of tests if you want to use them. So when we kind of ensure people are safe and stable, we use skills training to prepare them for therapy, making sure they have coping strategies, grounding strategies, anger management, perhaps, if they need it, and the safe environment to interact and if you like, learn their psychoeducation. So a safe environment is very important. And we could use medications. And of course, we have to assess risk. With medications, it's very important that in severe cases you consider this, because, of course, suicide is what's going to kill people. So it's very important not to miss a severe depression, for example. And of course, with alcohol, you cannot really treat post-traumatic stress disorder if people are going off and having a drink, because what they're doing then is not processing what you've taught them in therapy. They're just avoiding it. So that's really quite important. And the stance should be the medications are prescribed and they're monitored. And once people are stable, then they do their therapy. And then after therapy, the plan would be to review the medication and cut it down and stop it as much as possible, and maybe be off all medication. So just very briefly, I haven't brought many slides on medication, I've only brought this slide. So an antidepressant might improve symptoms of PTSD in its own right, and also depression. A major tranquilizer or a neuroleptic may improve hallucinations, dissociation, and tranquilize or calm people down. A mood stabilizer would reduce post-traumatic stress symptoms and stabilize mood, for example, emotional dysregulation. And anti-impulse medications would reduce impulsive self-harm, for example, or depression. So there are strategies that one can employ there. And very, very briefly now on trauma-focused therapies. As I've said, we use trauma-focused cognitive behavior therapy and EMDR mainly in the UK. The Americans use a process called cognitive processing therapy, which is the equivalent of our trauma-focused cognitive behavior therapy in the UK. There are other techniques that they use in America, like narrative exposure therapy and prolonged exposure. Now, the reason why I'm talking about these therapies is you may not have many skilled individuals to deliver trauma therapies, but you may have many skilled psychologists. So this is the advice I gave my own staff when I didn't have enough staff. If you're not trained to do trauma-focused cognitive behavior therapy or EMDR, then the easiest way to do trauma therapy is to use cognitive processing therapy. And the reason for this is it's very structured and very manualized. You can download a manual for your patient and a manual for yourself as the therapist from the internet. And I'll give you the link. The link's in the slides. Okay. So with EMDR, we don't quite know how it works. It's about envisaging or having an imagery of the traumatic stress, focusing on the anxiety, and then cognitive restructuring and eye movements as well. But people don't think that's absolutely essential. Other methods are tapping or counting. You do need training. The psychological theories behind EMDR are not clear, and it does take a while to be trained. So if you're not trained, I wouldn't try this, as it were. Trauma-focused therapy is more, if you like, in keeping with your psychological training. So it's about education and then working through of the trauma. So exposure, talk about the facts, what happened, the sensations, where are those triggers? So, you know, what did you hear, see, touch, taste? And let's look for triggers now that's causing symptoms. And then your emotions and challenging negative beliefs and hot spots, things that you don't really want to talk about, like feeling you blame somebody or you feel guilty, and doing cognitive restructuring and problem solving. And then, of course, using basic anxiety management techniques as well in the psychoeducation phase. And there are techniques to deal with blame, shame, and guilt. They're called compassion-focused approaches as well. So that's in a nutshell what is done. And the therapist helps the confrontation. You can actually do it verbally. The patient tells you about it. You can write it down, or you can, if you like, tape it and have a whole narrative of it. So it's a detailed recounting of what's happened, and you do expose yourself, and people can tape their disclosure of what's happened and listen to it many times and do some exposure work with it as well. This is cognitive processing therapy. It draws on cognitive and information processing models. It's quite easy to deliver. It's very, very commonsensical. There are 12 sessions. The first is about introduction and education, then the meaning of the event, identification of thoughts and feelings, remembering the trauma, identification of stuck points. So these are the hot spots, the difficult points that people can't easily confront, challenging questions, faulty thinking patterns, safety, trust, power and control issues, self-esteem issues, and intimacy. So this comes online as a whole package, and the manual for yourself and a separate manual for the individual. The key points are to deal with stuck points. So these we call hotspots when we talk about trauma-focused cognitive behavior therapy. Eventually people end up with an impact statement. They write quite a lot here in this therapy, how the trauma has affected me and how it will no longer affect me. So it is a written account. And then therapy will look at safety, trust, power and control, esteem, self-esteem, and intimacy. So it's about looking at areas of interpersonal functioning. This is quite an easy intervention to deliver even online. We've done research where I work at Combat Stress and at King's to show that this can be delivered online with very good outcomes, even with individuals who are quite seriously unwell with post-traumatic stress disorder. So we had very good outcomes. Of course, there are barriers to therapy that's effective. The individual needs to be trusting. The patient and the therapist need to be psychologically minded and qualified to do the therapy. There is a lack of training and supervision. Ideally, you need supervision if you're going to do trauma-focused work. Assessment needs to be quite thorough. If there's moral injury, it might be difficult. Guilt, shame, and blame are a problem. Traumatic bereavement is a problem. Comorbid illness, you know, is there a brain injury, for example, as well? Someone's been beaten on the head and you haven't quite assessed things properly. And is trauma still ongoing? Well, actually, at the moment it is. So personally, I personally wouldn't be doing trauma-focused work on refugees right now. They're seeing the trauma on the television. The trauma is not closed. They need to be supported right now with practical things using psychological first aid systems, as it were. Now, for the families who are outside the Ukraine, those who have arrived here already, we need to be assessing well-being and look for mental illness. If there is mental illness, you need to treat it. Most people won't have a mental illness. They'll be having emotional reactions, adjustments, difficulties, but they'll need practical support. But you do need to assess risk, evaluate the losses and bereavements, listen very carefully, a very supportive approach. Look out for risk-taking, for example, alcohol. Promote well-being, so exercise, good sleep, food. Promote coping skills. Deliver some psychoeducation, even if it's just a leaflet, just information. Tell them to keep their loved ones in their thinking, balance functional and dysfunctional behavior, as we've discussed. Prevent the anticipatory grief from completing. So if that completes, it might be a problem, as we've said. We don't know the whole effects of the news on television or social media or the direct link from the front line. So be aware of that. Prepare them and yourself for good news or bad news. So there are problems there that suddenly might occur out of the blue. And if there's mental illness, treat it if it exists. Okay, so I'm going to stop here now. I hope this has been useful, and I'm going to stop sharing my, let's try, my screen. That's it. Thank you.
Благодаря на Уолтър за презентацията. Преди да преминем към сесията ни с въпроси и отговори, ще имаме 5 минути почивка, като докато слушах, аз си мислех нещо, което е по-скоро около преживяването в тази група, не толкова около това, което Уолтър каза. И то беше, че някак в този формат, в който ние не виждаме всички участници и сме фокусирани изцяло върху темата и въпроса за травмата, може би има нещо, което отразява състоянието на тези хора, с които ще се срещаме, и тази невъзможност да видиш нищо друго, освен един единствен въпрос, който изцяло изземва ума в този момент. Имаме вече един въпрос от аудиторията, с който предлагам да започнем, след като имаме 5 минути почивка, след което всеки, който желая да зададе въпрос, може да вдигне ръка и Ирина ще даде думата. Това значи, че ще се видим обратно в 11:25 българско време.
Аз искам само преди да преминем към въпросите и отговорите, да напомня набързо, че може да задавате въпроси в секцията въпроси и отговори до Q&A в чата, или ако искате да се включите и да зададете въпрос с глас и картина, дигнете ръка и аз ще включа камерата и микрофона.
Добре, здравейте обратно от мен. Ще започнем с първия въпрос, който дойде в панела по време на презентацията. Той е от Димитър Гранчаров. И неговия въпрос е следния. Той е всъщност съпроводен и с малък коментар в началото. По време на операция Пустинен щит в Кувейт рязко нарасна броя на бременностите сред жени военнослужещи и помощен персонал в зоната на операцията. Имаше хипотеза за свързаност между опасността и желанието да дадеш живот. Бихте ли коментирал сексуалните връзки на бежанците като източник на сигурност, източник на вина? И още един свързан въпрос на Димитър тук е състоянието на домашно насилие в Украйна е почти същото като в България, широко разпространено. Много вероятно е сред бежанците да има деца, жертви на насилие. Ако имаме DSM-OS по DSM, това е буквално въпроса, и развитие на PTSD, какъв е добрия подход? Може би, ако имаме комбинация, какво правим, Димитър?
Right. Thanks for the question. I think it's interesting about, first we'll start with the sexual relations and intimacy issues. So they are quite complicated, and yes, I think prior to or as we go into battle, then maybe sexual activity can increase. But actually, if we then have a scenario where people are dying and my best friend has died in my arms, then many soldiers, certainly in my experience, come back from battle having great difficulty interacting with other bodies, as it were. So intimacy issues are a big problem for combatants, especially those who've been bereaved on the battlefield and have seen very serious injuries, especially to comrades whom they are very close to. So that's one aspect of it. The other aspect of it is if we look at the literature from the displaced persons camps after the Second World War. So after the Second World War, there were millions of people on the move in Europe, and many ended up in displaced persons camps because there was nowhere for them to go. Some of these had been victims of the Holocaust, so in concentration camps. Those in concentration camps had a very low intimacy and sexual activity. Their libidos were very, very low. And that was their last priority. Their first priority was to eat, if you like, when we look at the biological drives that the human person has. Those who hadn't been in the Holocaust itself, again, had very low rates of sexual intimacy. Again, it was not the priority for them. So I think what we will see is probably a mixed picture, but my experience is that it does depend very much on the nature of the war, the nature of the trauma, what the refugees are running away from, how long people are going to be separated from. In my experience with people who've been kidnapped or held hostage for many years, the last thing that reverts to normal is sexual intimacy. That is not a kind of first thing that happens between a husband and wife, for example, when they return or when the family reintegrates. So I think it'd be very, very variable. So I wouldn't want to predict what will happen. I wonder whether Kalina has experience of this, because I know you've treated refugees in the past, obviously you have.
Ами, аз като четох въпроса ми хрумнаха няколко неща и едното беше, че може би това, което Уолтър казва, е много валидно за дългосрочния ефект на травматичното преживяване. Наистина ветерани, които имат дълго време PTSD, имаха почти разбити семейства, например, в Босна. Но мисля, че във въпроса има нещо, което касае по-скоро възбудата по време на война. И тук се мисля за няколко референции. Едната е за една статия, която мисля, че 60-те години във Великобритания е била публикувана и тя е свързана с защитите срещу тревожността в социални институции, такива психиатри, въобще болници. И там мобилизацията на сексуалния нагон е доста висока. Мисля, че срещата с смъртта извиква някакво желание да се преживява живот. Другото, което се сещам, е една книга на Джоана Бърк, не се лъжа, която се казваше Интимна история на убиването, An Intimate History of Killing. И това представляваше проследяване на истории на ветерани от много войни, Виетнам, от Ирак, Афганистан. И това, което те говорят, е буквално за наслади по време на военната мобилизация. Това, разбира се, след това много спихва и всъщност наистина има голяма трудност да се възстанови двойката, но по време на самия военен опит, мисля, че това е много валидно. И последното, което ми хрумна, е как сдвояването, необщо казано, е често пъти защита срещу реалността.
Mm-hmm. I agree. I think the other thing that crosses my mind is many combatants, so soldiers, tell me that they become sexually aroused actually during combat. So that is you know, they say we get the rush, it's a big high, and then the context of becoming sexually aroused later. So I'm not saying in the war zone, but later on when they return home, there's a whole different context then. And their connection with having loving intimacy is lost because they've had these big sexual highs when they've been in combat. So it is a very complicated area, I think. And it's definitely worth looking at. But I do think probably every war will have a different footprint on this. And of course, it's culture bound. You know, if you have a very religious culture versus a non-religious culture, I think the meaning would be quite different. So, and the value of marriage or the value of not being married, I think all that is very relevant culturally. Shall I turn now to the second two parts of your question? I think you've talked about domestic violence and DESNOS, disorder of extreme stress not otherwise specified, or complex PTSD. And of course, we know complex PTSD is being classified now by the International Classification of Diseases, 11th edition of the World Health Organization in 2018. And that is, if you like, all the core cluster symptoms of PTSD, but with three other areas of difficulty, which are negative cognitive change, emotional dysregulation, and great interpersonal difficulties. So complex PTSD now has properly been defined in classifications. That's really important. And I think the question was, what interventions would you use? Well, the interventions that are easiest to use is something called the STAIR model, STAIR. So that's skills training in affective interpersonal regulation, and that's Marlene Cloyter's work. So Marlene Cloyter is somebody we're working with right now. We're doing a study into STAIR treatment. It's a randomized control trial in British Army veterans, and they're getting treatment as usual versus STAIR. And STAIR is probably the easiest, if you like, technique to use. It uses narrative exposure therapy. So there's a lot of writing and talking, but also it's very structured in terms of the psychoeducation that is derived really from dialectic behavior therapy. I don't know if you know about DBT in Bulgaria. That's a technique used to educate borderline personality disordered patients. And it uses techniques for interpersonal regulation and emotional dysregulation. So it's borrowed those two areas of dialectic behavior therapy, incorporated in the STAIR therapy. So that's really what I would recommend The other thing you could do if you really wanted to treat complex PTSD is go to John Breer's, B-R-I-E-R-E. So John Breer has a website. He's an American psychologist who's very gifted. He's written many books on how he treats complex PTSD as in an outpatient setting. Domestic violence, I think, is a big issue. We know from combat veteran studies that they come back if they've been exposed to, the more combat they've been exposed to, more death, the longer they've been there. If they develop PTSD as well or other mental health problems, the more likely it is they'll be angry and there'll be violent behaviors, including domestic violence. So that is a big problem, yes. In the British forces, we use the diffusing method where people coming back from Iraq and Afghanistan, for example, were taken to Cyprus on the way home for 2 or 3 days. They had a lot of psychoeducation. They were allowed to drink alcohol for the first time and start fighting amongst themselves to let off a lot of steam. And although this was never proven, it probably saved a lot of marriages and domestic violence. So some diffusing technique, if you have a lot of combatants suddenly coming back as refugees into Bulgaria, you need to think about some diffusing techniques maybe.
Имаме още 3 въпроса, които са пристигнали към нас в чат. Преди да видим и тези, които идват към Ирина с вдигане на ръка, след което още един, който е при мен в чата. Така че ще преминем първо към 3, които са хронологично предхождащи вдигнатата ръка. Първият въпрос е от анонимен слушател, който пита дали трябва да даваме отделна подкрепа на малките деца, в скоби 2-12 годишни, или най-важни са родителите им.
Shall I go first, Kalina, and then you?
Yeah, you can go ahead.
All right. I think, look, the main literature would suggest that the way the mother copes determines how the children cope. So if I had no resources or little resources, I would focus on the mother. Of course, I would want to look and see what's happening with the children. And of course, if I had more staff or extra staff, I would focus on the children as well and have them in small play groups. Of course, with children, they won't necessarily tell you they have problems. They'll display them in their behavior. So a lot of night terrors, perhaps, but also playing with violent games or guns or things like that. Or they might be very withdrawn and isolated. So I think you need to assess the situation. But usually if the mother is coping well, the children will be coping well. So I don't know, Kalina, what you want to say.
Аз съм напълно съгласна с това, което Уолтър казва и мисля, че работата с родителите, в случая майки са повечето тук, е първата важна, защото тревогата на майката обикновено е отразена в детето. И само в една добавка, около групите понякога, когато има много голямо количество деца. Сега тук не знам дали това ще се случи в България по този начин, по който в големи лагери има натрупване, но групите с деца работят много добре, защото структурират времето им също. Много пъти децата губят структурата на ходене на училище, градина и така нататък. И когато им се предложи структурирано време, това също има много контейнираща, много удържаща функция. Следващия въпрос, всъщност, той отново е свързан с деца и идва от Катерина Ковачева, която пита дали може повече информация относно първата психологическа помощ, насочена към деца-бежанци, също и какви са спецификите при реакциите на децата вследствие на война. И последно, какво и как комуникираме с другите деца в България, в скоби нашите деца.
Yes, I was thinking about this. Is a very interesting question because certainly here in the UK, they are asking for volunteers to take families into their homes. And of course, children will go to local schools who will have British children who have no idea about the war. And I think it's a big problem. I mean, it's easier if you're going to manage children together in a group or in a school or in a play group scenario in a refugee camp to a degree. Although, of course, nobody wants to go into a refugee camp. It's not a nice place. But I do think it's quite difficult. I think the psychological first aid for children is quite straightforward because it's all about support and keeping kids calm. It's not about intervention. So I don't think that's difficult. I think with children, you give them a structure, sports, activities. Of course, we have problems perhaps with the language barrier might be an issue. So that we'll need to kind of bear in mind. And of course, if we are mixed into Bulgarian school with Bulgarian children and maybe there are only 3 refugees, that will be a problem. But I think structure for children is by far the most important thing. I think we've already discussed the responses of children. So as I said before, they'll play violent games, they'll have night terrors, they might be withdrawn, they might come across as anxious, they may not eat. So it's very important to assess what's going on. I think Kalina will have more to add, because I think you have more experience with children in refugees than I have, for sure.
Аз не съм сигурна, че много ще добавя около структурата. Със сигурност съм съгласна. Мисля си, че така както комуникираме други въпроси около трудни теми, загуба, развод, смърт, психична болест, по този много директен начин, с уважение към тревогите на детето, които понякога могат да изглеждат нерелевантни или много малки, или примерно дете, което казва, че се тревожи, защото котето ѝ е останало в Украйна, или пък кучето, или е забравила любима играчка. Мисля си, че много важно е на това да бъде обърнато внимание подобаващо. А по отношение на тази последна част от въпроса, нашите деца, струва ми се, че по същия начин по-скоро трябва да обясним какво е войната, какво се случва на език, на който детето може да разбере, без това да е лишено от емоция, но и без да бъде твърде емоционално като обяснение, за да не въвежда допълнителна тревога. Мисля се, че детето би отразило много емоционалното състояние на говорещия по-скоро, отколкото съдържанието на това, което казва. Следващия ни въпрос е пристигнал на английски. Аз ще го прочета на български. Не знам дали Уолтър може да го види или ще го чуе прочетен от преводача. Той идва от Ралица Друмева, която пита какъв би бил съвета към работещите, как да успокоят хората, които преживяват тревога за потенциалната загуба на любими хора, които са в битка в момента. Например, майка, чийто син е мобилизиран да се бие, или съпруга, чийто съпруг е на бойното поле. Как най-добре тези хора могат да се справят с несигурността? Благодаря.
Yes, I think this is something I touched on briefly in my presentation, in that certainty and uncertainty are a big problem because, you know, now we have mobile phones, and I think I certainly was speaking to colleagues in Ukraine until, well, certainly last week easily, and this week I think a bit. So I think, you know, communications are really, really good for most people. If there's certainty, you know somebody's safe, and then the routine is that you try and communicate with your loved ones outside the country first thing in the morning, and that call doesn't come. Then people are left uncertain that day, and they can have a very bad day. But of course, the next day they do communicate, and so it's like a roller coaster, we would call this in English. It's up and down. It's a real problem. So I do think it's very important to give structure as much as possible. So say in the British Armed Forces, if a regiment was going into battle, everybody knew, the wives at home knew that there would be a time that they could not communicate with their loved ones. So I think it's important when you educate the refugees and say, yes, you're in contact with your loved ones, but you need to have a structured way of communicating and a way to kind of make sure that the uncertainty becomes more certain. And so people are not left hanging on because the internet has gone down or it's been blown up by the enemy. The other thing is you do need to prepare yourself. If you're managing refugees, you do need to prepare yourself for the time that bad news actually does come, because people will live in hope. So all this business about anticipatory grief, the hope that they will be safe, they will come back, and that maintains the relationship. So as I said before, people are going to be, if you like, emotionally, if you like, unsteady. But you do need them to remain like that, because if the anticipatory grief completes, they will pretend the husband has died. And that's a big problem when the husband comes back, and it can be a problem for the family. So it's all about supporting them, all about yourself as well, getting as much information as you can. So if you're looking after families from 1 or 2 areas in Ukraine, you need some information. Try and get as much information as you can, how the battle's going there. But that can be extremely difficult. So I don't have a clear answer to this, but Kalina might help me here too.
Не съм много сигурна. Аз мислих в посока на това как технологиите някак импортират войната директно в дома. Нали? Всякакви канали, всякаква информация е веднага налична. И ми се струва, че това както от една страна е успокояващо, защото дава някаква идея на време, по същия начин вдига тревогата, защото ние сме залепени постоянно на този канал на информация и всъщност ума е презалят от тази събитийност травматична. А може би наистина, ако може да се остави време, в което да се рефлектира върху това, което пристига към нас, и съответно и ако може това да се случи с засегнатите от конфликта, а да не бъдат оставени изцяло в потока на новини, които те така или иначе искат да следят. В този смисъл ежедневните структуриращи дейности за тях може би са от изключително значение. Просто ума да бъде ангажиран с нещо друго. Преди да минем в следващия въпрос от чата, имаме вдигната ръка. Така хронологично пристигна въпрос. Ирина.
Вдигнатата ръка от чата изчезна, но имаме въпрос от чата, който касае децата, които преминават границите сами, как се работи с децата, които пристигат без родители.
I think that's really tough, isn't it, really? I think a lot depends on how old they are. If they're young, then, you know, it's maybe easier. But if they're teenagers, children who have no connection to the country they've arrived in, that I think is very difficult. Again, you would use your psychological first aid techniques, put them in a safe place, see to their basic needs, listen to them, calm them down, try and connect them again to something or somebody, either back home or else ideally in your own country where other refugees have come from the same town or the same village. In the UK, we had experiences with children who were, if you like, sent to the UK just as the Second World War was starting in 1939. They were held in various institutions run by charities, but with a lot of family input, local family input. So I think there are many ways to do it, but if it's one isolated child, it's probably much harder. If you have 10 isolated children, then they can support each other. So I do think the group effect is very, very important, and trying to connect them to something or someone that they're familiar with is also very important. So I don't know, Kalina, you will have some more experience on this for sure.
За съжаление, опита в България с непридружени непълнолетни е жалък. И интеграцията и грижата за тези деца е много бавна, много непълноценна, поне от предходни кризи до сега. Със сигурност това, което се случва в ума е, че основният контейнер, основният удържащ обект не е там и нещо много се е провалило в това отношение. И всъщност новата среда трябва да предложи такава функция. Има законова рамка за непридружени непълнолетни. Между другото, тук е мястото може би да кажа, че можем да насочваме бежанци към организации партньорски за правна помощ. И може би не случайно това се сещам сега, защото всъщност да се въведе закона и някаква структура отвън е много важна, когато става въпрос за дете непридружено от родителите си. Но за съжаление този опит, структуриращ в България, не е много добър. Аз нямам представа колко са влезлите непридружени непълнолетни украински деца в момента и как те биват настанявани, но една от функциите на отделите за закрила на детето е тази да се погрижи. Мисля, че там трябваше да има назначен как се казва, такъв по закона отговорен, в момента думата на български не бяга, който да бъде в легалната позиция на родител. Но това представителство също е доста тромаво в много случаи. Много зависи индивидуално от това, кой служител се оказва наличен в някоя институция. Следващия ни въпрос идва от Ния Кирякова в чат. Само да кажа, че в момента е 12 без 10. Може би да удължим времето до 12:10. Не знам, Уолтър, какво мисли с 10 на минути, за да можем да посрещнем въпрос. И тя казва така: здравейте, благодаря за представени опити насоки. Има ли място и какво психоаналитичния подход в контекста на подкрепа на хора, преживели военни конфликти? Благодаря.
Wow. We say a lot about that, can't we? If we look at all the literature on Freud and all the psychoanalysts would have a field day today. The problem is we don't have weeks and weeks of therapy available anymore. Certainly in the UK, it's very rare now that you get to see a psychoanalyst on the health service. You'd have to pay a lot of money to do it privately. I think it's really important to recognize that very basic theories remain true. Dissociation is very important, especially with people being severely traumatized in multiple ways. The age and the developmental stage of the individual is very important in relation to trauma and what presents and when it presents in terms of symptoms, and when the onset of these symptoms comes alive, like, I don't know, being traumatized as a child and then later on as an adult trying to have intimate relations. So there's a lot that can be said, but I don't think psychoanalytical interventions in an early phase are necessarily the right way to go about things. I think you need brief interventions that are very supportive with lots of practical help, and years later maybe psychoanalytical approaches will be helpful and useful, of course.
Въпреки че с тази част, която казва, че в началото е много важно да имаме по-скоро отговор на базовите нужди, съм напълно съгласна, но си мисля, че психоаналитичният подход по-скоро е рамка на ума и е свързано с това как мислим за бежанската група или за това какво правим с един човек, който стои насреща и ни говори, и какво можем да чуем, искаме ли да чуем за нашите преживявания. Тоест този тип рефлексия може да бъде със сигурност психоаналитично информиран. И другото, което ми хрумва е, че много от психоаналитичните теории могат да бъдат полезни в работата с групи и това може да се случи в съвсем първите седмици и месеци от работата с деца, например. Мисля си и с ветерани също. Но се изисква малко, може би, да стъпим вън от стойката, рамката, в която ние ежедневно практикуваме психоаналитично информирана терапия. И да се опитаме да я нагодим към някой, който в момента е в нужда, за да нямаме бионовски мислено тази арогантност на любопитство и отношение без истинско чуване, без истинско съпреживяване, което се оказва, че може би е доста трудно. Следващия ни въпрос е от Джулия. И той е следния. Скоро се свързаха с мен с въпрос относно какви психологически препоръки могат да се дадат на родителите на дете на 12 години с аутизъм, което преживява кризи в бомбоубежището. Кризи, не е уточнено какво. Значи това какво може да се направи в този случай, за да се помогне?
I think that's really difficult. I think people who have had to stay back in the Ukraine, who haven't been able to become refugees, include a lot of, as you say, institutionalized children or children with very serious or serious mental health problems like autism, and of course the elderly, and they are stuck there. I think it's very difficult. I don't know what communication is available with these parents, but if I was in communication with them, I would try and check in with them on a regular basis to support them. The treatment of the autistic child, I don't know any literature that looks at the effects of shelling or bombing on children who are autistic or have pre-existing behavioral problems. There must be a literature, so I'd go and read about it, go and look for it. But I think it'd be a very difficult scenario for the parents and the carers. And they are part of course, as we said in the presentation, part of the disaster community that will need help, and probably they will suffer, they're more likely to suffer mental health problems in the long term. So they are at greater risk, I would say. The effects of on the children who are autistic, we know that people who suffer from these kinds of conditions are more vulnerable to develop post-traumatic stress and other mental health conditions if they're exposed to trauma. So in the long term, their prognosis is not good. They will need intervention, and they're very difficult to intervene with. So it is a tragedy, really, I'd say. I don't know, Kalina, you may obviously have more experience on this than me.
По-скоро само една добавка. Хрумна ми, че по статистика, това, което знаме, че в ситуация на такъв пълен разпад на всички институции, достъпа до всякаква помощ, която може би е била налична преди за това семейство, вероятно не е. И вероятно те са пред невъзможността да си водят детето там, където може би са, или пък ако той е приемал и някакви медикаменти, не знам дали могат да ги купят, дали ги имат, дали изобщо как това стои. Аз бих опитала малко да поговоря за това и за техните тревоги, колко те се чувстват в състояние да осигурят някаква устойчивост на грижата за собственото си дете и малко да поработя с техните трудности. А по отношение на аутизма, хрумва ми нещо, може би не съвсем централно тук, но по време на сирийския конфликт бяхме забелязали колко много всъщност се покачват психотичните симптоми, защитите от психотичен характер. И особено сред деца всъщност от един момент насетне имаше огромно увеличение на хиперактивност, на също всякакви дислексии, диспраксии, дори си мисля аутистични, такива аутистично изглеждащи аутистоидни черти, които може би в други условия няма да бъдат проявени по този начин. Така че можем да държим в ума и някакви проявления на аутистични черти като защитен механизъм и опит това дете може би да се изключи от реалност, която не може да понесе. Да, Ирина, може би има.
Имам два въпроса в чата, за да не се изгубят сред другите въпроси. Единият е: какви техники препоръчвате да използваме при съобщаване на лоши новини? В случай на смърт на близък. Въпрос от Мария Никола.
Yeah, that's really difficult. That's really difficult. I think what I would do with if I was looking after refugees, I would tell them before there was any bad news what we would do if there was bad news. So at least they're prepared. That's what I meant when I said prepare yourself and them for bad news, because it's very important not for things to come out totally out of the blue. So in the British military, for example, my wife and my family knew that if a priest and an officer came knocking on the door, it would mean that I had died in deployment. So there is a structure, at least there's some kind of preparation, and I knew as well that I would be supported. So I do think if I was looking after numbers of refugees, or even one refugee family in my house, I would have a plan for that. I wouldn't leave it to come totally out of the blue. And then I would tell them gently the truth. I wouldn't lie. And then we would see how we're going to manage everything else afterwards. So I do think it's very important to have a structure and to have a plan, really.
Ирина, преди да имаме ли още въпроси с дигната ръка, имаме два от чата, които ще прочетем и мисля, че имаме време за тях и евентуално, ако при теб има някой, можем да приключим.
При мен има един. Искаш ли да го поема?
Да, заповядай.
Въпросът от Инга Калчева. Първоначална реакция на паниката атаки, които преживяват хората в семействата, както и злоупотреба с алкохол, като следствие на загуба на работа, на бизнес, на нормалността на ежедневието. Какви насоки към близките и роднини около тях в такава ситуация бихме могли да дадем? Тоест, как може да помогнем на близките и роднините на човек, който преживява някакъв вид разпад или победна книжа?
I think this would happen in normal scenarios, wouldn't it, in any case, whether or not they were refugees. So I think it's important that, first of all, you ask permission from the patient, from the individual, whether you can speak to the relatives, because it's important that your knowledge as a clinician is confidential. So you must be sure that you have permission. If you can't get permission, or the situation is so dire that you have to tell the relatives, then you have to tell them. And I think you need to, as supportively as possible, tell the relatives what the matter is, and ideally as well, tell them how their loved one can be treated and how they can support their loved one. And if there are kind of dynamic issues between the relatives and the individual, you might need to treat that family in the longer term to come to terms with what has happened. So it's not perhaps just the individual you need to help. You probably need to help the family later on. It can be difficult, of course, if there's alcohol involved and that's been a secret. So you ideally get the individual to tell the family there is a problem with alcohol. If they won't or can't and don't want to, and you do have permission, you'll tell them. If it's a dire situation, you're going to have to tell them. So, I don't know, this is quite a clinical scenario.
И два въпроса от чата имаме. Единия първото коментар на Веселина Неделчева и ми се струва, че това е, мисля, частично отговор на един от предходните въпроси, как психоаналитичното мислене може да влезе в употреба. Тя казва така: ако детето играе игри с насилие, но не прибягва към агресивно действие в реалността, може би това е ефективен опит за преработка на травмата, защото фантазмата държа и едновременно с това се опитва да интегрира опита, чрез преминаване от пасивна в активна позиция. И последния ни, това вече е въпрос, идва от Анелия. Здравейте, бих искала да попитам дали е възможно да говорим за PTSD при хората от страни, които се намират в близост до държава, в която има война. И ако да, дали според вас принципите на работа са сходни с тези, които посочихте? Благодаря.
I'm not sure I got the whole question there. Look, the principles of treating PTSD are very straightforward. So the book to read, it's in my slides, is Judith Herman's book, Trauma and Recovery. It's very, very good, simple book. It's very short. It's not, it's about 200 pages long. And it describes how to deal with PTSD in a phasic approach. So a phasic approach, make sure that your patient or patients are safe, first of all. Make sure that they're educated in relation to their symptoms, to normalize their symptoms. Make sure you treat anything that can interfere with trauma-focused therapy. So that's the first phase, and that means depression or alcohol or drugs. You need people in the room to do trauma-focused therapy. You don't want them drinking before or maybe even dissociating a lot. So you might need to stabilize people first. So stabilization is the first phase. The second phase is trauma-focused therapy, where you get them to work through what happened. Whatever technique you use, ultimately, you need to overcome this big avoidance and help their mind to process. And that's really the second phase. And the last phase, which really starts at the beginning as well, is to make sure they have the means and the ability to reintegrate into society. So it's all about making sure they have family support, but also a job to go to, ideally, and a social life to go to, for example. So the principles are always the same, no matter what you're treating in relation to trauma. It's always about getting somebody to confront the worst possible experience of their life in a safe therapeutic window. And stabilization, trauma-focused work, and reintegration are really the three main principles.
Уолтър, благодаря за това представяне и за въпросите, които пое. За нас беше удоволствие и чест да ни гостуваш в този семинар.
Thank you very much for inviting me, and I wish you all well and good luck. And hopefully we'll meet again, and very happy to be here today. Thanks very much for organizing this. And I hope the war in Ukraine will be very short, and we pray for what is happening with all those terrified people.
Благодаря на всички участници. Да, и от мен до тук. Благодаря ви. Довиждане.
Преди да се тръгнем, искам да ви кажа, че по-късно ще ви изпратим запис от семинара, както и копия на презентацията на Уолтър. И ако имате някакви въпроси допълнителни, може да ги изпратите по имейл. Ние ще направим всичко възможно да ви отговорим по-късно. Хубав ден на всички.
Okay. Thank you. Bye. Thank you. Nice to meet you.